Welcome to a short video overview of the European Resuscitation Council's 2015 guidelines. I'm Dr. MACONOCHIE, lead author of the European Pediatric Guidelines. I'm going to focus on the changes in pediatric, basic and advanced life support guidelines. These changes are based on the interpretation of scientific evidence produced by the International Liaison Committee on Resuscitation Councils, which incorporates advice from providers, instructors, and educators to ensure the most effective delivery of paediatric resuscitation. Starting with paediatric basic life support. There are two main changes, the first being to bring paediatric basic life support more into line with adult practice by making the duration for the delivery of a breath 1 second. The second change is to clarify that the lower sternum should be depressed by at least 1/3 of the anterior-posterior diameter of the chest, or by about 4 centimeters for the infant and 5 centimeters for the child. For healthcare professionals, the algorithms for basic life support in children differ from the adult algorithms. Basic life support for lay people will also be discussed. Many children do not receive cardiopulmonary resuscitation because potential rescuers are not sure if there are specific methods recommended for children and are so afraid of causing harm. This fear is unfounded. It is far better to use the adult CPR sequence for the resuscitation of a child than to do nothing. Those lay people who specifically wish to learn pediatric basic life support can be taught adult CPR plus the following simple modifiers. Number 1, give 5 initial rescue breaths before starting chest compressions. Number 2, if you're on your own, perform CPR for 1 minute before going for help. Number 3, compress the chest by at least 1/3 of its depth. Use 2 fingers for an infant under a year. Use 1 or 2 hands for a child over 1 year as needed to achieve an adequate depth of compression. The ultimate aim is the delivery of optimal basic life support to promote the return to spontaneous circulation. Turning now to pediatric advanced life support. The algorithm remains unaltered from 2010. Changes in the post-resuscitation care include preventing fever after return of spontaneous circulation, and targeted hypothermia therapy after ROSC should involve either normal temperature control or mild hypothermia. Finally, the review of prognostic factors for outcomes following cardiac arrest have shown that there are no single predictors of outcome. The relevant factors should be taken into account when considering resuscitation. These factors are the duration of the arrest, the cause of the cardiopulmonary arrest, any comorbidities, the nature of underlying illnesses or injury, whether there's a shockable rhythm, or if there are special circumstances surrounding the arrest, such as drowning or exposure to reversible noxious agents. In summary, the main changes to pediatric basic life support are to bring them into more alignment with adult practice and to confirm that the depth of compression in the infant should be 4 centimeters and in the older child 5 centimeters. In pediatric advanced life support, the algorithm is unchanged, but there are changes in suggestion of post-resuscitation management.